So tonight we're going to talk about ovarian cancer risk management. And before I kind of click into a medical talk, I mean, ordinarily when we give these sort of talks, it's really to a medical audience. And this is very different, of course, tonight. And I just want to say that as much as I can tell you, I've studied this topic inside, outside, and backwards, and I've talked to thousands of women about some of these issues and these risks and, how complex and personal many of these decisions are. I haven't lived it, and I'll give my most authentic assessment of what it, where those choices land and what it, what the medical evidence is. But I want to be really clear, to be sensitive, to say, for many people who are listening tonight, you may have had experience with ovarian cancer in your family. You will be grappling with some of these decisions. And I just want to be really sensitive to say that I know this is not easy, any of this stuff. But where we're at now is I'd like to give you the very best medical advice that exists in 2023, tell you what the state of the art is, and let you know a little bit as well about our clinic. And so, as Katrina mentioned, we run our gynecologic oncology prevention and survivorship clinic. And so, looking at the list of all the attendees, I see lots of familiar faces and names. For anybody who is in the midst of making any of these big decisions about hereditary risk and gynecologic cancer risk and management, certainly our service is there to serve you. And we really do like to see people before they are jumping into any big surgical decisions and help counsel them about how to manage these, how to tackle these decisions, how to time these sorts of things, and how to manage afterwards. And so please don't be shy. If you feel like you would like to see our team, we'd be more than happy to see you at any point. And it's easy to find. You can find it through my name. There's some links as well on the BRCA and BC website, and just even through my name at VGH, and we'll be happy to help out. So, all right, let's talk about ovarian cancer. So these are sort of the basic things I thought that I would try to outline today. Obviously, we'll keep an eye on time, and I want to leave as much time as possible for questions and conversation, because there's lots of different things that are very personal and that individual people may want to raise particular circumstances. I can't give you exactly medical advice for your circumstances in this case, but we'd be happy to have as many questions and help as much as we can. So we're going to talk that requisite, what are the risks, talk about what the recommendations are, what are the risks and benefits of surgery and the non-surgical options, some advice about timing of surgeries, and I have a lot of opinions about this. And of course, post-surgery care, especially things like menopause management, and give you some really good news stories about where the future is heading, and in particular, some evolving evidence about the role of salpingectomy or fallopian tube removal alone. So with that in mind, I'll click into some of the medical stuff, and then we can ease more into more questions. So for anybody who would really like to read some more medical information, there's two really reliable sources that I can direct you to. The first of these on my left, is the Society of Obs-Gynae Clinical Practice Guideline. I work with many of these authors, and Dr. Michelle Jacobson runs a clinic very similar to mine at Women's College in Toronto. And so this is a guideline about management of gynecologic cancer risk in the context of hereditary breast ovarian cancer. If you can't get your hands on it, let me know and I can certainly send it to you. On the right side is American, but really it's quite international, is the National Comprehensive Cancer Network guidelines. And these are available free online. You do have to get a password. It's a big behemoth of a big medical document. But if you go about halfway down, you'll see a table with specific genes and what the recommendations are. And so this is for people that really do want kind of the more nitty-gritty medical stuff. Oh, sorry. So let's start off by talking about screening. So this is the slide that I hate showing because I wish it was different. The truth of it is that when we're looking at ovarian cancer, and unlike many other cancers that we know about, obviously breast cancer, we have mammography and breast MRI, cervical cancer, we have pap smear, colon cancer, we have FIT tests or colonoscopy. When it comes to ovarian cancer, unfortunately, we do not have any screening test that's ever been proven to be effective. And so this has been tested at a very high level with a lot of patients, huge trials, both in the UK and in the US, that evaluated blood work as well as ultrasound for women to see if we could detect ovarian cancer at an early stage. And in fact, what both these studies showed, very similar results in tens of thousands of women, is that ultrasound blood work is not effective. at detecting ovarian cancer at an early stage. So unfortunately, that's really why we end up heading toward these conversations about surgery, because we really just do not have a proven screening test that's effective. As we get further on in the conversation, I'll tell you about a new study that's launched and is here in BC called the CHARM study, which is testing out a new technology that's a blood test that's quite exciting. But for the moment, at this time, you cannot take any screening to the bank. And what I say to patients is, some patients will go ahead and they'll want to do ultrasound and blood work. We don't recommend it. It's not giving you any guarantee. And I certainly cannot look you in the eye and give you any assurances that an ultrasound would pick up anything in an early stage, unfortunately. So that's unfortunately where we're at with screening. In terms of risks, and I have a hunch most people will have already seen many of these slides before, but this is kind of the one paper that we rely on a lot that gives people a true sense of what the risks are. And these two graphs talk about both breast cancer risk and ovarian cancer risk. If you look at the ovarian, can people see my cursor when I do that? Yeah. So if you were to look at ovarian cancer risk here on the right, the population risk of somebody getting ovarian cancer who has 2 working copies, say, of BRCA or any of these cancer predisposition genes, so somebody with no mutation, their risk is going to be really minuscule. It's going to be about 1.3% in your lifetime. So quite low. Unfortunately, when we're talking about BRCA 1 and 2, those risks are substantially elevated. For BRCA 1, that risk is probably quoted at about 40 to 44%. And for BRCA 2, we would quote 15 to 20. Typically, I might say 17%. So we are dealing with, when we are found out to be carriers of BRCA, we are dealing with substantial increased risks. And that's really why we're all here today, because I can tell you from my own personal point of view, having cared for many, many women with ovarian cancer, if I'm engaged in the prevention of one ovarian cancer in my career, my whole work life will have been worth it, because it's such a terrible disease and the vast majority of people are diagnosed in an advanced stage. And so what we really want to see by all of this education and all of this support for carriers is that we can really give people the very best prevention and eliminate those risks to the best of our ability. So here we are. For many of you, you may have known you've had a high risk for some time. For others, it may be relatively new information. And the challenge is, how do you manage that risk? What are your strategies? What's your approach going to be? And how are you going to take those risk reduction strategies in the context of your own life, your own experience, your own lived experience in your family, your own medical story? And so just going around some of these pictures, I wish that we had the perfect pill to reduce ovarian cancer, but I will be able to tell you some good news about the birth control pill and ovarian cancer risk. Down below, we have an ultrasound of an ovary. I've already told you that we know ovarian cancer screening with ultrasound doesn't work. We are working on lots of other new screening tests, including this blood test with the CHARM study. And unfortunately, where we've landed at present is that, well, fortunately and unfortunately, I would say we do actually know in a really effective way how we can reduce ovarian cancer risk, and that is through surgery, which is risk-reducing salpingo-oophorectomy. And I'm not saying this like it's an easy decision, but I can give you some evidence about why it's such a highly effective intervention. Further to the screening point, before we get further into surgery, we do actually also have some screening data that's being collected and ongoing in high-risk women, because those other studies I showed you about were in the general population. One would hope that maybe in high-risk women, we could get a better signal for the efficacy of screening. There are a couple of very large studies ongoing that are collecting data now. Some of them have stopped recruiting, but are still following patients. So far, we do not have any evidence that even in high-risk people that you can take any screening test to the bank. Obviously, as those studies mature, we'll see what those results show. But again, nothing to rely on at present. And I have mentioned the CHARM study, which we'll talk about. So there is one pill that people can take that can substantially reduce their ovarian cancer risk, and that's the birth control pill. And we do have very good evidence. And this is a great example, I think, of why a situation where medical research didn't get promoted properly, because many people don't know that taking the pill even for 5 years results in a substantial reduction in ovarian cancer risk. And so if you're looking at 5 years, a 50% reduction in risk. And for many people with high hereditary breast cancer risk, they may also be worried about, well, is this a safe thing for me to embark on as a BRCA carrier because of my breast cancer risk? And in fact, the breast cancer data on oral contraceptive is pretty heterogeneous. You'll see lots of variation, but on balance, we're not seeing a strong signal that birth control pill use is substantially increasing breast cancer risk. So this is something for some women who may not be at all interested in surgery that they can do, but it will not give you anything like the kind of risk reduction you would get, of course, with surgery. But it's good to know about it. So where does that leave us? So this is a picture. I don't know if people have ever seen these kinds of pictures before, but when we do these sorts of operations, what we see, we put our cameras in and we can look and see in the middle, the uterus, and then on the sides, the fallopian tube and the white ovary. And this is exactly a good example of what these surgeries will look like. And so the procedure in question is called a risk-reducing salpingo-oophorectomy. And these graphs here on the side are a good example of the kind of risk reduction you get. So you see these little squares and triangles. If an intervention makes no difference, you would see these squares and triangles being number one, right up and down on the line, meaning there's no difference. If an intervention is worse, it'll go to the right. If it's better or improves things, it'll go the other way. And you can see from these very large studies that risk-reducing salpingo-oophorectomy substantially reduced ovarian cancer risk. And what's more, if you look at big series, looking at all kinds of all-cause mortality, not just ovarian cancer risk, you do see, in fact, a 70% reduction in all-cause mortality in women who choose to have this surgery. So this is there's not very many things, I dare say, in medicine that you see that kind of benefit with. So, I'd love to be able to say I have something else besides surgery, but at present, this is really very, very compelling evidence that surgery is a very effective thing that should be considered by people who are at very high risk. And just to kind of hammer that home a bit further, the Cochrane Library or Cochrane Review, or when researchers take all of the available evidence from all sources and put it all together and review everything in a really organized, systemic way. And again, when the Cochrane Review people have looked at this, risk-reducing salpingo-oophorectomy is highly, highly effective at reducing the chance of ovarian cancer, the risk of ovarian cancer death, and all-cause mortality. And I see Dr. Keifetz is here. If it comes up in questions, we can talk about the benefit or the potential benefit of breast cancer risk in certain gene mutations. But for the moment, I'm going to stick with ovary. And again, we have Canadian data and BRCA carriers as well, looking at this same question. And again, the people who had surgery really had a very substantial improvement in their outcomes and reduction in their ovarian cancer risk. So where does that bring us? Well, that brings us to the fact that pretty well every organization worldwide that's engaged in gynecology and ovarian cancer risk, the European Society of Medical Oncology, the Gynae-Oncologists of Canada, the Americans, the UK, have all made a very clear recommendation that the most effective thing for somebody who's got BRCA would be risk-reducing salpingo-oophorectomy. And so there's an age range that we can talk about more, but what we do with this is we look at when do we start seeing ovarian cancers happen in a particular gene, and we try then to recommend the surgery before that curve starts to increase. And because we know that BRCA1 carriers have ovarian cancers at a slightly earlier stage, the age range that this is recommended at is between age 35 and 40. For BRCA1 and BRCA2 between 40 and 45. I did want to just pop this up very carefully. Oh, sorry about the graphic. I did want to pop this up for anybody who has not had surgery, who's embarking on it. What I tell people in our clinic, and I'll see lots of familiar people here will remember me saying this to them, it is very important if you're going to be having surgery that the surgical team, and most gynecologists will know this, are aware that when the fallopian tubes and the ovaries go to the laboratory to be analyzed, that there's a very specific analysis of the fallopian tubes called the CFIM protocol. And in essence, what that means is, if you can imagine my pan is your fallopian tube, we're not just looking at one or two sections, we're looking at every single section of the whole fallopian tube to make sure that we're not missing any early pre-invasive changes that could be detected by looking that closely. One of the big questions that comes up a lot is people trying to decide whether or not they would consider or need to add hysterectomy to their surgery. And so this is an ongoing debate. There's a lot of, I've been to many, many medical community debates and discussions about whether or not hysterectomy should be included. I will say that in my practice, I do not routinely recommend hysterectomy for people with BRCA mutations. There have been some series that have questioned a slightly higher uterine cancer rate in BRCA1 carriers alone. But those are very, very low findings, in my opinion, at least, and that of many groups, is that you are adding more complications to the time of your surgery. Adding hysterectomy does make it more complicated. And because of that, on balance, really it's the fallopian tubes and the ovaries that are the most important. And so for that reason, we do not routinely recommend the addition of hysterectomy. I am going to stop for a second. I'm just getting a signal from my computer, despite the fact that it's plugged in, that I'm low on charge. So I'm just going to, if people will bear with me 1 second, I'm just going to triple check that. Yeah, this should all be fine. Everything looks okay. If I cut off, I'll come right back on, but it looks like I'm okay. All right. So these are the big questions, and I suspect this is where many of our conversation will go tonight, is people really want to know, okay, so if I understand this is a medical intervention that's so effective, what can I expect? I obviously, I'm not keen on being menopausal earlier than I have to be, but this is the decision I'm prepared to make because of the clear evidence that this reduces my risk. What can I expect? So what we know is that, when a woman does have her tubes and ovaries removed, you will suddenly have an acute surgical menopause. How does that show up? Well, that may show up as hot flashes, night sweats. For some women, they may feel that they have decreased libido, and some women will have things like vaginal dryness. And I'm happy to talk in great detail about any of those things. People who are on the call in our clinic know we spend a lot of time talking about all these topics. The good part of most of this is that the vast majority of patients who do decide to have surgery in the absence of a prior breast cancer can absolutely take hormone replacement, and in fact should take hormone replacement, and can do so very safely. And that mitigates the vast majority of quality of life concerns. I'm not saying that replacement is 100% and that people don't notice the difference. They do. But that in our clinic, by supporting people and really caring for them in a very thoughtful and attentive way, we are able to help women navigate these menopausal symptoms very effectively and maintain their quality of life in a meaningful way. And so no doubt we'll talk about that more. My experience would be that the biggest thing most people find in the end, once we're able to manage their hot flashes and menopause symptoms, would just be trying to manage some of the long-term side effects of menopause and risk reduction on those things, which we'll talk about. And also probably the libido question. Many women will still say they feel like their libido is less. And that medically makes sense because the postmenopausal ovary, even if we go through menopause naturally, does still secrete some androgen or testosterone. So we can talk about that more. Where are we with the role of hormone replacement therapy? So we know, and I'm going to qualify all this by saying that for women that have already had a breast cancer, it is currently not recommended that we give you hormones to manage menopausal symptoms. So for our ladies that have had a prior breast cancer, we use non-hormonal management methods to manage menopausal symptoms. And we have a whole list of those that work very effectively. The vast majority of women, if they haven't had a breast cancer, absolutely can take hormone replacement therapy. And we do have good evidence that this improves your quality of life, decreases hot flashes, improves sleep, sleep disturbance, and will in fact protect bones and cardiovascular disease, which are risk factors for having a premature menopause. You can get the feeling, I think, from this that this is complicated stuff, and there's a lot, I could quote papers and papers, but the gist of it, I would say, is that hormone replacement therapy for somebody who's not had a breast cancer before has been shown to be quite safe. And I'll show you some papers there. I'm just watching time. So we have lots of research. We have several series of women who have had BRCA, who've had tubes and ovaries removed, who were given hormones and were not, and we are not seeing a signal that they have an increased incidence of breast cancer when they're given hormones. And in fact, because the oophorectomy, maybe even for some gene mutations, may lower their breast cancer risk, you're not getting an incremental increase. So we have lots of good research in big series now saying that not only do hormones not increase your breast cancer risk, but they do substantially protect your quality of life, your cardiac risk, and your bone outcomes. And I imagine there'll be lots of questions about that too. We do need to be very thoughtful about proactive healthcare. And that was really one of the core principles behind us founding our clinic, is that we had seen in British Columbia that BRCA carriers who had surgery, fewer than 50% of them were ever given any hormone, and the vast majority of them didn't continue at more than 2 years. And we did actually see that those same women had higher rates of osteoporosis and cardiac disease, and they weren't getting the kind of prevention and screening that they should have been getting. And so that's why we've launched our clinic. And people who are in our clinic will know that part of that's our clinic has a research component where we're planning over long-term to follow women and prove that by giving people ongoing support and navigation, that we can mitigate a lot of these negative things by helping out with prevention. Katrina, I see your camera comes on. Are you giving me a heads up to wrap up? No? Okay. So the other big thing that I really want to talk about, and there will be lots of questions, I imagine, is this question about fallopian tube removal only. And so where does that come from? And that comes from the fact that let me phrase it this way. When I started in practice in 2001, we didn't really know what the actual carcinogenic process, what the actual origins of ovarian cancer were. We didn't really understand it. Now, in no small part because of BRCA carriers who were having preventative surgery, and we were able to look at the pathology, and then more deep analysis of high-grade serous ovarian cancer, which is the kind that we see in BRCA carriers, it's now become clear that the fallopian tube most likely is the source of these cancers rather than the ovary itself. And so when you hear that, the first thing you're going to think is, well, wait a second. Maybe I don't need to have my ovaries out. Maybe I could just have my fallopian tubes out. And that, I would say, is the big question of 2023. And the thing that we're all most excited about is, could it be that by removing fallopian tubes only, we're going to be able to get to a point where women can delay the oophorectomy part and therefore avoid an early menopause? The truth is, though, the evidence isn't out yet. And so I just came back. I was in the UK this summer and spent a couple of weeks doing an observership with the big UK team that are leading this question in the biggest study in the world called the Protector Study, where they're following about 1,200 women now that have joined this study who were just choosing to do fallopian tubes first and then subsequent oophorectomy. And this study, as well as another one in the UK and one another one in the US and another one in Europe, are going to hopefully answer that question. The challenge at present for those people that are in the middle of these kind of decisions right now in 2023 is that I can tell you that ovarian cancers start probably in the fallopian tube. I can tell you that I think there will be risk reduction with fallopian tube removal alone. The problem is I don't know what the extent of risk reduction is. So I'm not able yet to tell people what kind of risk they might be taking if they were to just have fallopian tubes out and not ovaries. So that's why none of the organizational groups, none of the guideline groups have changed any of their recommendation at this time, because we don't know enough safety data. So I'm excited by the prospect of this, but I don't know whether that risk reduction is going to be, is it going to be 50%? Is it going to be 80%? We just don't know. And until we know, nobody feels that it would be very safe to gamble with a disease like ovarian cancer. So the studies that we're watching for are Protector study, Dr. Ranjit Manchada in the UK, Tuba Wisp out of Belgium, and the US one. And in fact, here in Vancouver, we're hoping to open either the Belgian one or the US one here for our patients. So stay tuned. Nothing at present that I would recommend anybody go outside the upper age limit of the gene recommendation for their age. But it could be helpful for some people if, say, you've already finished your family, you're sure you're done childbearing, you need a means of permanent contraception. It would make a lot of sense to me as a BRCA carrier if I needed a permanent contraception that I might choose to have my fallopian tubes out rather than, say, having a Mirena or having a tubal ligation. But that doesn't mean that oophorectomy is off the table at present. So I want to be really careful not to get people's hopes up too much and to qualify where the barriers are and where the evidence is not clear. And so I'm going to kind of wrap up. I will say Dr. Janice Kwan, who's my partner in the clinic, is published on this and has done a lot of modeling about how effective we think it might be, but we don't know yet. Protector study, I stole this from the UK crowd. So they've been recruiting and they've got, what happens with that study is women choose if they want to go straight to oophorectomy or if they want to have fallopian tubes now and oophorectomy later. And when I was there, I think there were about 1,200 patients, and their plan, the way the study is designed is it's designed around quality of life outcomes. And they're just in the process of hopefully getting funding to expand it to 3,000 women so that we'll have cancer-related outcomes, which obviously is the thing we really want. You can imagine that these studies are very complex to deliver and run, but I can't begin, if I ever felt inspired and hopeful about BRCA care, I cannot tell you what I came away with following this UK team and working with them this summer. I came away feeling so hopeful that it's going to be really different. And for those of you that have daughters that you're worried about, let me say mother to mother, it's going to be different by the time those girls are grown up. I really felt very hopeful coming back from that learning opportunity. And then again, I've already mentioned this, the American trial, SOROC, there's only 2,000 patients. Data is not due for another decade, probably. And then the European one, same story. So we don't know when we're going to get data out of those about cancer risks. We do know already that the quality of life outcomes, not surprisingly, in the women who choose to have salpingectomy are better than the women who have their ovaries out. So obviously the women who have their tubes out are not yet menopausal. So this kind of a no-brainer, but obviously it was enough to make a publication. But it goes without saying that if you haven't had your tubes out, you've had your tubes out, not your ovaries, you're not yet menopausal. So no surprises there. And this is the last thing I want to wrap up and say, this is a really personal choice, and personalized care has to be at the center of this. This is not a one-size-fits-all kind of intervention. And every single patient I've cared for, back-to-back patients with the same exact mutation who are the same age, and their choices are different for lots of reasons. Their lived experience, maybe they lost their mom to breast cancer, maybe they lost their mom to ovarian, maybe they inherited it on their dad's side and they never saw anybody with cancer. Maybe they've had a breast cancer before, maybe they have fertility concerns. It's going to be different in everyone, and that's really why we founded our clinic. A few just practical tips. This is not in a book anywhere, but I have a very strong opinion on this part, which is I think if a patient is coming off a breast cancer diagnosis, or if they're having mastectomy and reconstruction, because those are such difficult interventions that I don't like to see people combine oophorectomy and acute menopause with breast surgery or breast cancer treatment in the same year. I feel like it's just too much to tackle. You will see women sometimes for whom their worry is their leading quality of life, or they're thinking a lot about their time off work or their disability or their sick benefits and that kind of stuff. But on balance, if you have the choice, let's just say you're going to plan breast surgery and reconstruction, try to space it out a bit because it's a lot to tackle at the same time. And again, our clinic is there to help. And this is the last thing I want to show you. So this is one of my beloved patients, who was one of my very, very first BRCA ladies. And when I met her first, we had no idea, but she had told me that her mom had had ovarian cancer like she did. And I did her debulking in 2001. She had very bad ovarian cancer, and she lived for an additional 12 years with very good quality of life because she had really chemosensitive cancer. And she was from this huge, big Newfoundland family, tons and tons of relatives. And I've had the privilege of caring for her sisters, nieces, granddaughter, and now great granddaughter. And I can tell you, we are not seeing ovarian and breast cancers in this family, in these women now. This is a good news story. And Emma would be so proud if she couldn't see now the impact that we've seen in these families. And the reason she loved that I had this picture. She's the only person I ever met who ordered chemotherapy to ordered pizza to a chemotherapy unit. And I'd never seen it before, so we took her picture. But she would be so happy to know that we're talking about this now, that it's better understood, and that it's such a good news story, that we're able to prevent these cancers in such a meaningful way. And with that note, I will wrap up. This is our clinic. We're at the Diamond Center. This is a virtual clinic, so we serve people from all over BC. The vast majority of people I see right here in this same desk where I am now. For people that do need an in-person, we'll see them happily at the Diamond Center. But we see people from all over, and it can be done virtually, on the phone, whatever you're comfortable with. And we spend lots of time managing menopause and hormones. And so with that, I'll stop.